Hello, everyone, and thank you for joining us for OrthoAlliance's OrthoInsights educational webinar series on overcoming arthritis. Tonight's speakers are Dr. John Martin, Greg Sarkisian, Scott Stevens, and Adam Miller. In addition to our OrthoAlliance physicians, Christopher Havelock, the Executive Director of the Arthritis Foundation in the Central Ohio and Toledo markets, will be speaking about what arthritis is and the many tools that the Arthritis Foundation has to help patients navigate the disease. Also, the speakers are going to answer your questions following the presentation. So if you have one, and when you have one, we ask you to be interactive and participate with the Q&A box at the bottom of your screen. So we will include all of the questions and the physician's answers on our OrthoInsight webinar series blog. That's located at OrthoAlliance.com. So make sure you check that out after tonight's webinar. So at this time, I'm going to turn it over to Christopher from the Arthritis Foundation.
Excellent. Thank you so much. I'll go ahead and quickly share presentation. All right, here we go. All right. Well, hello, everybody. My name is Christopher Haverlock. I'm the Executive Director for the Arthritis Foundation here in Central Ohio. The Arthritis Foundation is a national nonprofit organization dedicated to helping people with arthritis live their best lives. And we do that through a significant amount of investment into science to find treatments and hopefully eventually a cure, patient education and support, and advocacy. For my part in today's presentation, I'm going to be providing some very basic information about arthritis. We'll spend a few minutes sharing some Arthritis Foundation resources, all of which are free and available to all of you at any time. I'll also be sharing some contact information for myself and for my colleagues in Indiana and the rest of Ohio. So you're welcome to reach out to any of us at any time. We're always happy to receive your questions, your emails, and your calls. All right. So what is arthritis? Knees, hips, shoulders, elbows, these are all examples of joints, the parts of the body where two bones meet and move. And the word arthritis itself is a medical term that literally means joint inflammation. But arthritis, it refers to a group of over 100 different diseases. Arthritis affects not only joints, but sometimes also other parts of the body, like the skin and organs or tissue around a joint. Let's talk about some facts and figures surrounding arthritis. This slide, in fact, says quite a bit. 1 in 4 Americans has arthritis, and that's more than 60 million people in the US, including hundreds and hundreds of thousands of children, making it the #1 cause of disability in the United States. So just think about that for a moment. As the leading cause of disability, arthritis is far-reaching and it truly affects everybody. It's also very expensive. It threatens quality of life in numerous ways. We at the Arthritis Foundation are making a difference in the lives of people with arthritis by helping to save millions of dollars in healthcare costs. There are, as I've said already, over 100 types of arthritis, but we certainly won't be able to spend time talking about all of them. But today you're going to hear quite a bit, I imagine, about osteoarthritis, which is a major form of arthritis. Sometimes people refer to it as wear and tear arthritis. The doctors on our call today are going to be getting into some depth on that topic, I'm sure. Gout is also a type of arthritis that many people have heard of, and there's also many autoimmune and inflammatory forms of arthritis. And as I've said, children can get arthritis too. Something many people, excuse me, don't realize. It's not something that just affects older people. And again, juvenile arthritis is an autoimmune form that affects, probably 300,000 plus children in the United States. So if you've got a question about these or any other types of arthritis, the Arthritis Foundation can provide you with information and resources. My contact information again will be on the following slide. You're always welcome to reach out. I highly recommend you spend some time on the Arthritis Foundation website, www.arthritis.org. It's an excellent source of information. Here are some services and activities that perhaps would interest you and that you can get involved in. Right off the top, volunteerism. We are a volunteer-driven organization, far fewer staff across the country than prior to the pandemic, but we have always engaged volunteers in support of the arthritis community, and you can do that on a local level, a national level, getting involved in events and other programs. We provide community connections, so maybe it's an annual conference, maybe it's a support group, tons of ways in which to get engaged and involved with a wonderful and very resilient community. Education, local and national education opportunities abound, really. We have a Live Yes Toolkit. We do several podcasts and webinars. And of course, all of this can be accessible via our website. We do have a helpline. We have social workers and experts who are really on standby around the clock to help individuals, caregivers, anybody who's experiencing arthritis with problems or whatever their needs may be. And events, we have so many events. The Walk to Cure Arthritis is one of our flagship events. The Jingle Bell Run is another that you may have heard of. Here in Central Ohio, we have an annual charity auto show, which has been going on for 41 years, and it's one of the country's largest and favorite car shows. So if you're ever in the Central Ohio area in July, look us up. We'd love to have you come out for that. And then, of course, advocacy. We do a lot in local governments and up on Capitol Hill to advocate for the needs of people who are living with arthritis. And it's an excellent and easy way to get involved with the Arthritis Foundation. So if you just view the advocacy page on our website, you can sign up to get action alerts and just real easy way to get involved and to make a difference. And as promised, here's the contact information for myself and my recently hired development manager, Lizzie Howell. My colleagues in Cincinnati who also oversee the Kentucky market, David Rode and Matthew Overstreet, and then Indiana, my contact, Sandra Messner, our colleague rather, Sandra Messner and Idella Gates. So you're always welcome to reach out to any of us. I'll be sticking around, happy to answer any questions if anything should come up. And at this time, I'm going to turn it back over to you, Matt. Thanks for having us again on your program tonight.
Awesome. Thanks, Christopher. Thanks for the work you're doing. Much appreciated. And now we're going to turn it over to Dr. Martin, who's going to be talking about hip arthritis.
Okay, can you hear me? All right. My name's John Martin. I'm one of the joint surgeons focusing on hip and knee replacements at Central Indiana Orthopedics, based out of Central Indiana. Thanks for including me today and let me talk about hip arthritis. So the first question I was tasked with is, when should you see a specialist for hip arthritis? And really, in my opinion, it's anytime. Anytime you're having pain around your hip, I think it's appropriate to see a specialist who manages and treats hip arthritis. Especially if you're having hip pain that limits your function and your quality of life, I think it's definitely important to see a hip specialist. And especially if you're in that category and you've failed non-operative measures, I would definitely see a specialist who evaluates and treats hip arthritis. When it comes to hip arthritis, there's really two treatment categories. And the first one is conservative measures. So it's rest, activity modification, ice, anti-inflammatories like Aleve, ibuprofen, Motrin. I think physical therapy has a role for conservative measures, whether it's working on gait training and balance training, whether it's helping you use your assistive device if you use a walker or cane, or even more high-level things like strength and endurance training, flexibility. I think weight loss is definitely an option and it's a good option for conservative measures. Losing 1 pound of weight translates to 4 to 6 pounds of pressure off your hip joint. This is definitely a team-based approach through the physician, patient, nutritionist, and dietitian. And in my practice, I think corticosteroid injections are another conservative option that we have for hip arthritis. As Christopher was talking, as you have thinning of your cartilage, you end up getting inflammation, which causes pain in the hip joint. Steroid injections, in my mind, serve two roles. One, a therapeutic role where the steroid targets that inflammation and hopefully decreases that inflammation and decreases your pain. The second option and the second role for a steroid injection is diagnostic value. Typically, 90% of patients that I see in clinic have pain in 1 of 3 spots around the hip. Typically pain in the groin or in that front pocket. Worse when you move your hip around, do activities like getting in and out of a car, up and down a step, usually is due to hip arthritis. Pain on the side of the hip hurts when you press there, hurts when you lay on it at night, it's usually bursitis. And then pain in your back pocket or that gluteal region, especially if it radiates down your leg, is usually coming from your back. A lot of people, their pain doesn't read the textbook and they can have pain in multiple locations. So I think doing a steroid injection into that hip to see how much relief one gets from their pain can be of great diagnostic value. Whenever you've exhausted all those measures, you have significant pain, it limits your function, it limits your quality of life, then we start talking about the second treatment option in the form of a hip replacement. Hip replacement surgery entails removing the head and part of the neck, resurfacing the cup or the socket with a cup, and then putting a stem in the femur, and the head goes on that stem and articulates or goes with the cup. And essentially is depicted here in this X-ray. I like implementing robotic technology in my hip replacements. There are 3 main features of it that I find useful in my practice. The first one is it gives you a lot of information. It starts off by getting a CT scan of your hip in order to get 3D imaging. You can see this X-ray on the left is how we plan out our hip replacements if we're not using robotic technology. And then with the CT, it gives me information to best fit the components to that patient's anatomy and really customize where I think the components should go to best fit their anatomy and recreate their biomechanics. And you can see here that all these screenshots are tools and information that the CT scan's given me and the technology's given me in order to end up with an X-ray that looks like this. The second caveat of robotic technology is the dynamic joints balancing. So one thing we found in orthopedic literature is there's a lot of reasons why patients can be put at risk for dislocating their hip. And we found that one of the reasons that put patients at risk for dislocation after hip replacement is spinal stiffness from arthritis or a fused spine. This has been carried out in the literature. And in my practice, what I do is I get X-rays of the patient's lumbopelvic junction, so where their spine meets their pelvis, and I see how much it moves when they're sitting and when they're standing. I'm able to take that information and plug it into the software and the technology and then run impingement free range of motion simulations. So based on how stiff their spine is, I can see where their hip would impinge or hit, and that puts them at risk of dislocating. With that information, I'm able to change the position of the components by a few millimeters or a few degrees to best lower the risk of that patient's dislocation. And the literature has shown that while using robotic technology, we can not only lower the risk of dislocation, but we can lower the risk of needing a revision or a redo surgery for dislocation. And the third part is carrying this plan out. So it's great to have this elaborate plan, taking into account the spine, change the components where you want them by a few degrees or a few millimeters. But it's tough to do that without using the robotic technology to that precise and that accurate a level. So the haptic technology allows me to remove the appropriate amount of bone, as well as put the components exactly where we want them and really execute that plan that we have. And so once we do the hip replacement, what can we expect after surgery? And so patients are usually up and walking the day of surgery using a walker. Patients either go home the same day or stay one night in the hospital, depending on several factors, from degree of how bad somebody's hip is to medical issues and comorbidities. Typically after surgery, like I said, you're using a walker, then you progress to a cane, then you progress to nothing. Some patients will have restrictions based on the approach that they get. Whether if it's a front approach or a direct anterior approach, typically I don't have any restrictions for those patients. If it's a posterior lateral approach or a posterior approach, usually I'm doing 8 weeks of posterior hip precautions. I like outpatient physical therapy for hip replacements. That's controversial. I think getting up, getting ready, getting to therapy is life therapy. And then when you get there, working and walking and gait training is important. The questions I always get are, when can I go back to driving? Really, that it's two factors that allow you to go back to driving. One, you have to be off narcotic pain medications. And two, you have to be feeling comfortable to slam on the brake in case of emergency. Everybody's a little different. And when you meet those two criteria, I think that's when it's appropriate to return to driving. If we do your left hip, you end up going back to driving a little quicker than if we do the right hip. The other question is, when do I get to go back to work? Again, this varies. Everybody's different. Everybody has different jobs and physical requirements at those jobs. If you log on remotely, kind of like we're doing tonight, you could go back at probably 2 to 3 weeks. If you're slinging luggage at the airport, you may be looking up to 3 months. But there's always, again, everybody's different. And then people are usually returning to activities of daily living between 6 weeks and 3 months. And I think the total recovery time for a hip replacement is 6 to 12 months. Usually, again, in that first initial postoperative period, we're working on walking and gait training, but then we transition to strengthening and then stamina and endurance. And that's a whole year-long process. You go from seeing day-to-day and week-by-week changes or improvements to more month by month when you get into that 6th, 7th, 8th month time frame. And so I hope this was helpful. Thanks for letting me speak on hip arthritis, and I'll be happy to answer any questions in the Q&A. Thank you.
Great, awesome. And that's just a reminder that if you do have a question, it can be used in the Q&A, and we will get to those at the end of the session. And now we're going to talk about knee arthritis with Dr. Sarkisian.
Okay, can you guys hear me?
Yep.
Okay. Thank you for having me. My name is Dr. Gregory Sarkisian. I'm from Precision Orthopedics in Northeast Ohio, located in Chardon, about 30 minutes east of Cleveland. And we're happy to be helping out today with the webinar. I'm going to talk today about knee arthritis. And again, the first question, very similar to our last presenter: when should you see a specialist? I'm going to take a half a step backwards and just cover some of the basic things about arthritis. These were already covered a little bit before, but for those of you joining in now, basically the most common type of arthritis is osteoarthritis. Certainly, as discussed earlier, there's many types. The cartilage is broken down at the end of the bone, and then you have exposed bone, and the bones are rubbing together and causes significant pain and disability. It's a disease of wear and tear. Usually it happens in older folks, but we do see it in some younger folks as well. Genetic predisposition has a lot to do with it. So if your mother or father had arthritis, chances are good you may have it as well. But also overuse and injury are common reasons for arthritis. The symptoms, oftentimes stiffness, aching and swelling, night pain or pain at rest, inability to perform the daily activities which you enjoy or which you need to do. Many times with knee arthritis, you'll notice people have deformities of their legs. They have bow-legged deformities or knock-knee deformities. And this is oftentimes something we can correct at the time of a knee replacement. So we can straighten the legs out and restore a normal gait. So when should you see a specialist? Well, again, we see people at all phases of care, but certainly if you fail the conservative options, that's the best time to see a specialist. When your quality of life decreases and you can't do the things you enjoy doing, it's time. What kind of treatments do we have for knee arthritis? Well, there are several. Conservative treatments should absolutely be tried by everyone. And I always tell patients, again, weight loss is important, modifying your activities, doing low impact exercise. I'm a big fan of water exercise and bicycling, as I feel those things are kind of non-weight bearing exercises. And people with hip and knee arthritis sometimes can get away with pedaling an exercise bike or a regular bike and doing water exercise to help lose weight and get in better condition. Oral medications, as discussed previously, with non-steroidal anti-inflammatories such as ibuprofen or prescription strength meds. Acetaminophen or Tylenol also is helpful for people who can't take those medications. There's a lot of holistic medicines for arthritis, and if you go to the drugstore, you may see a shelf or 10 of many things that are out there now for holistic measures and other things. And some of these things have some benefit. There's turmeric and glucosamine and many, many others. Sometimes these things do help my patients and sometimes they don't, but it's worth a try. There's also topical agents for people who can't tolerate oral medications. And there's some pretty wonderful topical anti-inflammatory medications as well now that are readily available. We do a lot of injections for knee arthritis, and many people can get by for a number of years with injection treatments, whether it's cortisone, hyaluronic acid injections. Popular injections these days are PRP, which is plasma-rich protein, where we actually draw blood from the patient. You spin down the blood and get the plasma and can inject that into a knee or a hip. And oftentimes you can get some relief that way. These are all temporary measures. Bracing is also done for knees. A lot of patients come in wearing sleeves, which is okay. And oftentimes we use unloading braces, which are braces that take the pressure off of the arthritic compartment. And people can be more active and maybe play tennis or do their activities without pain or with less pain and prolong the ability, or the need, I should say, for hip replacement surgery. But when these options do fail, it's time probably to see your surgeon and discuss knee replacement surgery. So what can you expect after knee replacement surgery? Well, I've been doing this for a long time, and I can tell you that it's probably the most changed operation that I've seen in the last 25 years or more, where patients used to have to be in the hospital for 10 days or longer, and then they'd go to inpatient rehab and have to stay there for quite some time. Nowadays, it's pretty much outpatient across the board. There are some patients that are sick that have medical conditions, heart conditions, and so forth, that may spend one night in the hospital. But by and large, most people go home the same day. The pain control is also markedly improved. I give credit to my anesthesia colleagues who have come up with some wonderful blocks or types of injections that we can use now prior to surgery that make a big difference. Patients used to have significant pain right after surgery. And that was the worst part of the pain, is the first day or two. And now, for the most part, that pain is missed. It can be blocked with different types of injections. And we also inject the knee at the end of the operation with some medications that diminish the pain significantly. It's not unusual for me to see my patient in the post-operative area, and their pain level can be a 0 or a 1 on a scale to 10. And that's pretty typical. Now, the pain's coming, but it's not, you've missed the miserable pain. So that's the good news. You don't have that severe pain that people used to always have. And you can return to your activities sooner with the modern techniques. There was minimally invasive techniques that were popular years ago. I still think that some of that has been adapted to less invasive techniques surgically to decrease the trauma to the tissues around the knee, to allow quicker activities and back to work and sports and so forth. Below, you can see some photos of incisions and outcomes of knee replacement. What can you expect? Well, outpatient surgery, we get the patients walking right away. Usually within an hour or two, we let patients do full weight bearing on their knee. Usually it's with a walker, and they use a walker for usually about 1 week. And I have my patients advance to a cane in the opposite hand, usually by week number 2. And most people can walk without assistance after 2 weeks. Some people are ahead of that curve and some people are behind that curve, but that's about the average. Most patients these days are not on the narcotic medications like they used to be. Many patients can go without narcotics at all. Some patients, it's a limited use for the first week or so. But typically there is an increased pain. I tell all my patients that there's going to be a bump in their pain about 4 to 6 days after about day 5, when the swelling is most significant and they have stiffness, soaring, it's black and blue. And I don't see them that first week on purpose. I see them 2 weeks after, because by then they're doing quite a bit better, but there is a little increase in pain, and I warn my patients of that. The activity return is quite soon. A lot of patients return to golf before 6 weeks time, pickleball 10 weeks, tennis 3 months, and back to work again, as discussed prior lecture. It depends on your job. A lot of people work from home. They can work from home pretty quickly. And, if you're digging ditches or working construction, you're going to be off probably 3 months. Full recovery in 1 year. And I remind patients of that, because you're going to have some swelling and some stiffness that persists for more than a month or 2 or 3. And it gets better and better over the first year. Very limited risks with the knee replacement, 1% chance for infection nationwide, less than 1% chance for a blood clot or a DVT, deep vein thrombosis. And the majority of patients have a good, excellent result and are very pleased with the result, and oftentimes come back very soon for their other knee. I believe that's the limit of my lecture. We also do robotics surgery as well, which helps, again, as discussed in the prior lecture, guide the cuts more accurately. That's all I have. And again, I'd be happy to field any questions at the end. Thank you.
Matt, you're muted.
I apologize for that. Thank you. Still do it 4 or 5 years after using Zoom all the time. Apologize for that. Thank you, Dr. Sarkisian. We appreciate it. Now we're going to talk about shoulder arthritis with Dr. Stevenson.
All right. Is that make sure that's going through. I have the same problems with Zoom. You go. Let's see. All right. All right, here we go. So I've been tasked with talking about shoulders and specifically arthritis related to it. And so a little bit about myself. I grew up in Northeast Ohio. I did my undergrad in Cleveland, Ohio, and my residency in Columbus. I did 2 fellowships, a minimally invasive arthroscopy fellowship in Miami. I was fortunate to work with the Miami Heat, and then a shoulder and elbow reconstruction fellowship, and been in practice a total of 10 years now. So as I mentioned before, really, arthritis is the loss of soft cartilage that covers the ends of the bones. And there's a variety of different causes for this. It can be either degenerative, or the most common osteoarthritis, inflammatory arthritis like rheumatoid or psoriatic arthritis, if you have bad trauma, or for specifically what we can see with the shoulders for patients with long-standing rotator cuff tendon tears, we can get rotator cuff tear arthritis. And whatever the cause is, it's a loss of the smooth cartilage at the ends of the bone, allowing exposure of the underlying subchondral bone and pain. And the shoulder anatomy is made up of 3 main bones: the humerus, the scapula, and the clavicle. It's a ball and socket joint with smooth cartilage at the ends of those joints. And we have 4 rotator cuff tendons that wrap around the top of the humerus to allow all the range of motion that we see with the shoulder. So once you see a shoulder specialist, honestly, when you have pain greater than 3 months, but if you can hear yourself cracking when you're walking around the corner, that's probably time to see a shoulder specialist. And the most common symptoms we see pain at night while trying to sleep, especially when it gets quiet and dark and cold out. Pain during daily activities affecting the quality of your life, catching and popping, stiffness, loss of motion. And the first step we do is we obtain an x-ray. The x-ray really tells us the extent of the arthritis. And the classic hallmark symptoms we see with that is loss of joint space, bone spurs, sclerosis or hardening of the bone, and bone cysts. And if we let this go for a long periods of time, it can start affecting the joint line, losing bone, and changing the overall biomechanics of the shoulder joint. So what you should expect when you see a shoulder specialist is first, you'll get a thorough medical history, because a lot of the different medical comorbidities we see can really affect our decision in what shoulder replacement we use, if we should undergo a shoulder replacement, or if there's any conservative treatments that might be more effective for you. When we look at physical examination, the first thing we see is motion. When we get long-standing arthritis, and especially when it progresses, we can see loss of motion, crepitus with that, or catching and popping with it. We always want to look at the strength to see if the rotator cuff tendons are intact. We see if there's any instability of the shoulder joint or shifting, as that humeral head will shift in and out of the socket. As mentioned before, we always get x-rays to see how advanced that arthritis is. But depending on what decision we're making, we'll sometimes get an MRI to look at soft tissue, such as the rotator cuff tendons, or even a CT scan to look at how the quality of the bone is, and for preoperative planning. So what are the available treatments for our osteoarthritis? Pretty much the same as we have for knee and hip arthritis, in that the first thing is if it hurts, don't do it. We do activity modification, anti-inflammatories, steroid injections, as mentioned before, platelet-rich plasma or PRP injections. Physical therapy helps maintain the motion, though sometimes it's hard to get more depending on the degree of arthritis. For patients who are very young and have a mild arthritis, we can sometimes do a shoulder arthroscopy. And as shoulder arthritis advances, we can start thinking about doing a shoulder replacement. So a shoulder replacement is very simply you're replacing the ball and socket with metal and plastic, and it's extremely common. The incidence of shoulder replacements is actually outpacing hip and knee replacements as our technology has advanced, and we're doing more than 100,000 of these per year. And the key is really knowing the reason we've had such huge advancements is because it was kind of slow to start with beginning. The first shoulder replacement was in 1893 for tuberculosis patients. And looking at that prosthesis, you can see it didn't do very well. And it was really took about a half a century before the design started improving. And the father of the modern shoulder design, Dr. Charles Neer, completely redesigned the shoulder replacement, looking at hip replacements, and was able to kind of get the more modern replacement we have today. And now we have more than 70 different design techniques that has truly advanced the role of shoulder arthroplasty in patients who are living with shoulder arthritis. And the more modern shoulder replacement have improved design and materials. We have different metals now, such as titanium, pyrocarbon. We try to be more bone preserving. Instead of the older stems, which had long stem that filled up the entire canal, we now have a lot of stemless implants that do a great job preserving the bone and recreating the normal anatomy, more anatomical. We have modularity, meaning that we can switch from either the reverse or the anatomic without having to rip the whole implant out, which has really helped for revision surgeries. And the combination of this has resulted in improved pain relief, better function, more range of motion, and implants are lasting longer. And we have two types of shoulder replacements, unlike knee and hip replacements, because we have to rely on the rotator cuff for motion, either the anatomic or the reverse shoulder replacement. So for patients who have an intact rotator cuff and arthritis or avascular necrosis, we can do an anatomic shoulder replacement. And that simply recreates the ball and socket just as they are and allows us to get rid of the ends of the bone that have the loss of cartilage. They notice, though, for patients with a specific type of arthritis and long-standing rotator cuff tendon tears, that when they put a primary or anatomic shoulder replacement in there, the function wasn't any better. They'd still have pain and discomfort. They found out that an anatomic shoulder replacement in the setting of a rotator cuff tear just wasn't functioning very well. And you see early loosening of the plastic component with these patients. So for the reverse shoulder replacement, it takes a ball and socket and reverses them. By doing that, by putting the socket on the humeral side, we can have a deeper socket and allow the two implants to overlap slightly. That helps replicate the function what the rotator cuff does by stabilizing the shoulder and allowing the big muscles such as the deltoid, the pec, the latissimus to have better function overall and allow people to lift their arms up, which before they weren't able to without having the balance and stability of the rotator cuffs normally provide. And this was first developed by a French surgeon in 1985, and it took about 2 decades of success before the FDA finally approved it in America. But in the last 2 decades that we've had it, the design has dramatically improved, allowing better functionality, better improvements, and expansion of the different indications that we use for it. It used to be for patients with just rotator cuff tears and arthritis, and now even for patients who just have arthritis, we can even consider doing a reverse shoulder replacement because of the quality of the outcomes. So really, the design has improved dramatically. I was a shoulder fellow 10 years ago, and what we were using then versus now is completely different. Patients used to say, well, if I wait 5 years, it could be dramatically better. And I used to think, well, it'll probably be that much better, but actually it's been dramatically different compared to where we used to be. Our designs have improved. There's better augmentation or filling in of any kind of bone defects, overall more anatomical design. We have patient-specific instrumentation or implants that can be made or implant guides that can be made directly for the patient. We use that from the CT software that allows us to actually take the bone, make a 3D model of it, and try different implants in it. And in the last 6 months to a year, we've actually designed patient-matched implants where we can actually design an implant from our software planning. I can hit a button, it's made in France, and they ship the implant over that we can put directly in the body, and we can essentially create exact implants we want for patients. So who needs a shoulder replacements? Really patients who are having daily pain affecting the quality of their life. Pain while sleeping at night is probably my number one indication. Loss of motion or weakness of the shoulder. And patients have failed conservative management consisting of cortisone injections, oral anti-inflammatory pills, and physical therapy. And shoulder replacement nowadays is performed either in the hospital or more commonly in the ambulatory surgery center now. Medicare has allowed this to be an outpatient procedure starting January 1st. So we're doing more and more of these in the surgery center, which have a little better outcomes from the standpoint, less infections, faster recovery, better patient satisfaction. On the day of surgery, we do a nerve block, which helps numb up that whole arm. We still put you to sleep, but that way we kind of control the pain throughout the night for the first day. Patients are usually discharged either from the hospital the next day or even the day of, depending on how well they're doing. The therapy is pretty consistent nationwide in that we do a sling for about 6 weeks. After 2 weeks, we get physical therapy going. 6 weeks, we begin unrestricted passive active range of motion. And then strengthening begins at three months. And the outcomes show that we have a dramatic improvement between 3 to 6 months, but these keep improving up to 2 years later. And most patients are extremely satisfied with the results. The satisfaction rates have been greater than 90%, and a lot of patients are able to return their pre-surgery activities such as golf and tennis. And people always ask how long these last. And really, at 10 years, the survivorship is between 90 and 95%. So, and even at 15 years, the survivorship is 85%. But the reality is those are implants from 10 to 15 years ago. The quality's improved dramatically. So we're hoping for even better outcomes as implants have improved and the materials we're using has improved. Thank you, guys.
Awesome. Thank you, Dr. Stevens. Much appreciated. And now we will talk about ankles and ankle arthritis with Dr. Miller. And Dr. Stevens, I think you'll need to stop sharing your screens.
All right.
All right, Dr. Miller.
All right. All right. Good evening, everybody. My name is Adam Miller. I'm with Beacon Orthopedics down in Cincinnati, Ohio. And I'm here to talk tonight about ankle arthritis. So ankle arthritis in general, other arthritis it's a very common diagnosis. We usually think of kind of wear and tear as a way to think about arthritis. And that really refers to kind of the osteoarthritis, which is a very common arthritis in some of the upper joints and upper extremity. But actually, ankle is quite different. You can see here that the joint spaces in an ankle are relatively routine on the left. But if we look at the right image, we can see some of the changes in the ankle. And we'll get into these a little bit later. But for the most part, you can see that there's not a nice outline around here into the joint. And there's some joint narrowing as well. So as I said, ankle arthritis, really the differential is a little bit changed from some of the hip, shoulder, and knee that you've heard about. Trauma is by far and away the most common reason we treat ankle arthritis. People break their ankle or they break their tibia, and the incongruities and the changes there create this arthritis over time. Now, of course, people do have osteoarthritis, and we think that's probably genetics combined with some inflammatory changes we don't really understand, but that's much less common in the ankle. Other reasons that I see, people roll their ankles. Ankle sprains commonly that are left unchecked over time can be a significant problem. And there are other small percentages such as inflammatory and rheumatoids as well. Now, if you look at the X-ray more closely, as we were getting into, you can see some of the changes that occur. In this X-ray, you can see some of the cysts that form along the distal, what we call the end component of the tibia. You can see some of the spurs, in other words, extra bone that forms as well. And really the space, we can't see cartilage on an X-ray, but we can see the space where the cartilage is. And that space has been diminished. Most cases, this diminishes over time. Most patients think that arthritis is just kind of a slow linear development of pain. And that's good to think about for over a long period of time. But most patients will see upwards. It's more like the stock market. We have a general trend, but the up and down can often be changing very rapidly. When patients present, there's a few things that they're going to complain about. Definitely stiffness in the ankle. It doesn't function the way it used to. And probably loved ones are starting to notice things as well changing. Altered gait, the speed with which they're getting around. Maybe they can't really get up the ladders or stairs like they used to. One thing that kind of distills ankle replacements and ankle arthritis different than other types of joints that do replacements is the type of motion. Ankle motion is a little bit different. It's not just a simple hinge. Hips are generally considered to be a ball and socket type joint, a sphere going into the joint itself. But ankle has several degrees in a different arc of motion. And that really makes that complex interaction difficult to reproduce. And it also makes it a little bit more challenging for when we begin to treat these as well. So the good news is that there are some good treatments, and non-surgical treatment is almost always where we start, of course. That's safer for the patient, and there are some good options out there. Usually physical therapy is advantageous, and what that does, it will strengthen the rest of the lower leg around the ankle to hopefully offload some of the arthritic symptoms that the patient has. A brace, and there's a multitude of braces out there. We will often prescribe custom braces for some people that can't get around as well, and that's designed around the ankle. But there's also sport braces like this that are helpful in some cases. We often do injections in my clinic, and that can start with something such as a steroid or a cortisone injection you may have heard of. Those are mostly for pain relief regarding and relating to the arthritis. But there are actually biological agents that we'll use, and those are maybe referred to as stem cells in the popular literature, but really what they are is blood products, and they're concentrated to get a reaction from the body. And finally, medications such as anti-inflammatories, if they're medically appropriate, those can sometimes be helpful. So as a patient that has ankle pain, when are you starting to consider surgery? Well, the major answer would be when some of those other treatments are failing. Things are becoming more difficult. Maybe the injection you had is wearing off quicker. All these kind of lead to a conversation that you have with your surgeon about, is it medically safe? And is it also reasonable to start performing and thinking about that surgery? So going into the good news of surgical treatment, there's really three things in ankle arthritis that we try to do for a patient to help their pain. The first one is ankle arthroscopy, and I'm really kind of including this here for completion, but really ankle arthroscopy deals with very mild arthritis, not end-stage arthritis, and more focal changes. Think about a road that has a pothole on it. That may be a good indication for ankle arthroscopy, very focal spots that have wear and tear in the ankle. But really the more workhorses for end-stage severe arthritis are going to be ankle fusion. And that is where the two bones in the ankle, the talus and the tibia, are fused and made one together, usually through hardware and screws implemented into the joint. And then also ankle replacement, which is akin to some of the other replacements that you've heard about already tonight. So how do we decide what is right for the patient? Well, of course, that's an evaluation in the clinic. We start by really just kind of learning more about you, the patient. We want to hear about what you do, what is important to you, what kind of work do you do? And that really gets into also What are the medical issues? Your age, all sorts of things really play a role to understanding what is the most appropriate care for you as a patient. During that evaluation, we're also going to do a thorough exam. We're going to look at you and look at the motion you have in your ankle, look at how much strength you have. Are all the tendons and the muscles working appropriately? Is there neuropathy? In other words, the nerves, are they malfunctioning, or is there appropriate sensation and function? And then also imaging. It's standard procedure that we get x-rays in the clinic. And those are really looking at the broad spectrum of alignment of the ankle and the foot, which is a very important component to it, but also looking at some of the arthritic changes that we've already discussed. Now, advanced imaging has come a long way, and this is a CAT scan here on the left, but this really helps us understand some of the three-dimensional changes. Some of our total ankle replacements now often use these for planning and custom jigs to make sure that the implants work appropriately. And MRIs are also helpful to gauge for other type diseases of arthritis and the other soft tissue. So let's get into ankle fusion. Now, ankle fusion has been really considered the gold standard for quite some time. This has been the workhorse for going back decades as ankle replacements have become more into the popular culture and more common. The benefits are obviously pain control. You can expect to have pain control when the bones where the arthritis is, there's no more joint. A fusion basically removes that joint, so the joint pain related to the arthritis should be gone. We usually also use this for people that have more labor-intensive type jobs. Maybe they're significantly heavy. Maybe they have other issues that preclude them from having a successful ankle replacement. And in addition, once the ankle is fused, it's pretty much done. You can go home and we're done from a relationship, and you can move on with your life because we don't have to keep following these over time. The negatives, though, would be that your ankle is fused, so you can't have the motion that you once did while you were doing normal walking prior to your arthritis. And we feel, and we've seen this in literature, that over time, the adjacent joints in your foot will often have arthritis seen on x-ray, and that will often, over time, translate into pain in different areas of the foot too. So we call that adjacent segment arthritis. Now, ankle replacement has gone through several generations of different types of replacements. This is just one example here on the animation on the right, but they all have very similar components. There's two metal components, basically, that resurface the tibia, which is the long, big bone in your leg, and then the talus. There's a plastic component in the middle, which is made up of a plastic we call polyethylene. We select patients based upon significant criteria that we feel are going to be successful for the ankle replacement. So in general, and these are not hard rules, but most patients are going to be over 50 years old. They're going to be of less weight, so less than 300 pounds. And these are patients that are not going to be running a marathon. They're not going to be doing aggressive activities, but this is kind of something you have to talk to your surgeon about. I always tell my patients that doubles tennis would be about the level of activity I would expect you to want and be able to do. Now, the expectations are that we're going to have improved walking ability. That's one significant difference from the ankle fusion. Your pain relief should obviously be better. And our current literature says that about 10 years out, 80% of the ankle replacements are still in the patient and they have survived and doing well. So as an example, here's an example that I did myself of x-rays where you can see the arthritis that we've gone through and see the changes. We've recreated the joint space. We've realigned that so that it's appropriate and stable under the foot itself. This is one patient of mine that really had significant trouble walking. She had years of pain that was really struggling even getting into the office at the time I met her. We had really done a full evaluation of her, and we had actually identified that it wasn't just her ankle, but actually she had significant deformity in her foot, and this was something to consider. I had mentioned before that the alignment is very important for arthritis in the ankle as well. We want to make sure that if we're putting in a total ankle replacement, that the longevity is significant, and that includes neutralizing everything, the leg and the foot underneath. And she had a great result where we were able to reconstruct her flat foot, but also provide the ankle replacement in the same sitting. And she did very well. And at 3 months out, she was able to significantly get through her activities and really get back to some of the things that she was interested in doing. This is her in the office at about a 3 month timeout. So in postoperative time period, what would you expect? Well, after an ankle fusion, we keep you non-weight bearing for about 6 weeks. And this really includes using walkers, crutches, sometimes what we call knee rollers to really get around safely. After that, you start walking in a boot, and that's variable how long you be in the boot. Really, physical therapy is quite minimal. Remember, we're fusing the ankle, so we're not asking it to move. You might use physical therapy to try to learn to use your gait more appropriately thereafter, but it's much less important than it is in the ankle replacement. We try to start physical therapy and ankle replacements about right when the incision heals, so a few weeks after the surgery. And most patients are beginning to walk a little bit earlier after ankle replacements, about 4 weeks out. We'll also use the boot so they can start advancing as the ankle continues to heal. Thank you guys so much for paying attention tonight. And we'll get on to the questions, I think, shortly.
Great. Thank you, Dr. Miller. And as we've mentioned throughout the night, the Q&A is now open, still open. So if you have questions, this is your time to interact with the physicians and get some of your questions answered. But we'll start with a knee question, because I think this came in during the knee discussion. Dr. Sarkisian, how long in general are knee replacements expected to last?
Good question. And they actually have lasted a lot longer than back in, when I first started doing this. I tell my patients that we can expect 20 years, usually without too much question. And some of the recent studies show upwards in the upper 20s, 28, 29 years results for knee replacement, which this is a model of here. And, the polyethylenes, the plastic bushing between does last a lot longer. That used to be the weak link. So now they have better plastics. So these things do last a lot longer. Good question.
Great. Another question that we have, and we may have a difference of opinion, I don't know, but if you are a candidate for knee and a hip replacement because of arthritis, is there one that should take priority over the other?
Well, I'll talk about this first, if you don't mind. If I have a patient with a hip and a knee, I tell them to do the hip first. Usually people can have referred pain to the knee from the hip, but not the other way around. So oftentimes some of the knee pain, or maybe a lot of it, can go away or be diminished after a hip replacement if it's on the same side. So I usually do the hip first. I don't know what my colleagues think.
Dr. Martin, you want to add to that?
Yeah, absolutely. And I agree with that. That's where I rely on diagnostic injections, especially if I'm concerned for hip arthritis causing for knee pain. But I typically do the hip replacement first. It's easier recovery as well compared to the knee.
Right. The question that we have is about knee replacements. If you are over, 75 and you're into your 80s, is a knee replacement no longer viable?
Absolutely viable option. I tell patients that we don't go by their chronological age, we go by their health. I've done patients in their mid-90s that are healthy and active and have failed conservative measures and passed the medical tests that are necessary to have a knee replacement. I also have patients who might be younger in their 50s who are too sick to have a knee replacement. So I think it's more about how healthy you are than your actual age by the number. Certainly 75 is right in the ballpark, and 80s are common, even into the 90s.
Great. We'll go back to the ankle for just a second. Dr. Miller, can you expand a question that we've had is activity level? You said doubles tennis, I think. Can you expect to run with a full ankle replacement? What should the expectations be in general?
If the cars come and get out of the way, run out of the way. But so it'll function to run in those cases, but we don't really encourage patients to run on a regular exercise type basis. You could be on like in various machines in the gym. That would be something that would be appropriate. But we've seen more kind of aggressive advancement of deterioration in patients that are super aggressive hikers, they're climbers, they're runners. Those are the types of patients we really worry about the deterioration of the implant prematurely.
Great, thank you. This is a twofold question. A little bit about why would if someone is dealing with a failed knee replacement and is in need of a revision, would it be feasible still to have a replacement or a revision even with advanced years? That's a follow-up question.
Yeah, I think the answer is similar to my previous answer. Some patients, these knees do fail at some point in some people, and I see them all the time that they come in from all over. And yeah, absolutely. If they're healthy enough and they're 85 years old, we revise a lot of knees in patients that are certainly of advanced age.
Great, thank you for that. Dr. Stevens, I think is it true that we've been seeing more shoulder replacements with younger candidates? Has that age gone down? And if there is an issue, are revisions or replacements of a total shoulder, can that be done?
Yeah, we're seeing as our technology's improved, we've become more comfortable doing it. We've seen younger patients. The shoulder makes it pretty easy because we don't have to walk on it. So when we do shoulder arthroscopy and do rotator cuff repairs, it can be pretty painful procedures. Shoulder replacements actually are a lot less painful. The technology is now more stemless, so we're preserving bones, so younger patients are getting it. We're seeing the indications for the reverse shoulder replacement expand to younger and younger patients. We've seen the longevity of that improve as the technology materials improve. So absolutely, we're seeing younger patients. The incidence of shoulder replacements is actually outpacing, at this point, hip and knee replacements, which is still a greater number, but the actual percentage is going up much higher with shoulder replacements. So yeah, we're seeing it much more frequently.
Right. We tend to get a lot of questions about golf. So Dr. Martin, about hip replacement, when can a patient that's in relatively good health expect to be playing golf again?
It varies. I think starting around 6 to 8 weeks, I tell people to, progress into it, whether you're starting to putt, chip around the green. I wouldn't go to the driving range and try to hit home runs with your driver right off the bat. And then once you feel comfortable doing that, working through your bag, starting with the 9-iron, 8-iron, 7-iron, and kind of easing in. And then when you go out, I would ride a cart, maybe play 9 a few times before you do 18 or try to walk 18.
Great. Thanks for that answer.
Absolutely.
We'll take okay, here we go. I'm going to try, I might have trouble in pronouncing this, but prostatic versus osteoarthritis?
Psoriatic.
Psoriatic. I've heard that, never seen it written, so my bad. Any doctors want to comment on that?
I'll say a couple things. Again, a lot of psoriatic arthritic patients have the same symptoms or very similar symptoms to osteoarthritic patients. It's different because oftentimes it's associated with a psoriatic rash on the knee or elbow or other spots. These treatments are no different, honestly. It could be a little bit more aggressive in some folks as it is an inflammatory type of arthropathy, but the treatment options in the knee realm are unchanged.
I would agree with that. I think I've had a couple of patients where the plaques of the psoriasis were right over where I was supposed to operate, so we had to delay the surgery. But in general, the treatments, non-surgical and surgical, are the same. I really try to harp on rheumatology to make sure that the inflammatory disease is as controlled as possible. And then also working with them because of some of the immunosuppressants that these patients take. We need to make sure that we're planning the surgery appropriately because of the wound care that needs to go into the ankles. Ankle incisions just don't heal as readily as shoulders and hips often. So that's something that we take into account. And then finally, usually the outcomes in rheumatoids or inflammatory in general might be slightly worse than osteoarthritis or trauma. There's some studies that show that, but it's all viable.
Great. Well, we have met the end of our time together. Doctors, thank you so much for sharing your wisdom with us and a little bit more about your practice. It's much appreciated. Christopher, thank you for being with us to talk a little bit more about the Arthritis Foundation and the work that you're doing. So, and thank you if you're attending for participating in tonight's webinar. The next in our series will happen on May 22nd from 7 to 8 p.m. We have Dr. Benjamin Pulley, Dr. Ugler, Dr. Westerheide, and Dr. Pressel. They're going to be speaking on arthritis and some of the same issues, but different issues that we've been speaking on tonight. And you can register for that at our webpage at OrthoAlliance.com, and you can click on the events page to make sure you register for that. So we hope you all have a great evening. And once again, physicians, thanks for sharing your time with us this evening. Have a great one.
Thank you.
Thank you.
Thank you.